أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. My dear students and fellows, we were talking about this subject previously in my two lectures, and these are the valvular heart diseases. The valvular heart diseases, I have talked about the mitral valve disease previously, mitral stenosis separately, and mitral regurgitation with some words relating with the mitral valve prolapse also been shared with you. These are the pretty long topics to discuss, and that is why it is difficult to cover in such a small space. I try my best to do it. We have talked about these things already done. So this is session number 3, and it means that we are starting the aortic valve diseases. Now, aortic valve, we know, is the valve which is placed in between the ascending aorta and the outlet of left ventricle. Start with the session 3. The question has been decided, but before going onwards, now repeat the cycle, cardiac cycle, that the blood from the lungs are drained into the left atrium and then into the left ventricle, and in between the valve is mitral valve. And then in systole, the blood propels out a stroke volume in the ascending part of the aorta, and the valve is the aortic valve on this side. On the right side, same happens. There is a venous superior vena cava and the inferior vena cava influx into the right atrium, the deoxygenated blood into the right ventricle through the pulmonary artery into the lungs. There is a valve between the right atrium and right ventricle, which is known as tricuspid valve, and a valve between the root of the pulmonary trunk and the right ventricle is known as pulmonary valve. The first sound occurred because of the closure of the mitral and tricuspid valve and opening of the aortic and the pulmonary valves. It coincides, equivalent to the systole, while the closure of the aortic valve and the pulmonary valve will constitute with the opening of the mitral valve and the tricuspid valve. The element with the aortic valve is with the pulmonary valve. So the second sound is produced by the closure of the aortic valve and the pulmonary valve. So S2 means that it components is aortic A and pulmonary component P, A2, P2, that's it called. S2 in bracket, P2, P2. There is small space between A2 and B2. The gap is very small, and we can appreciate. And aortic stenosis is a very important disease to discuss. Discussion is very important. The aortic valve disease. aortic stenosis first of all. Now the pathology of aortic stenosis, the same as I will say the mitral stenosis. Maybe congenital, it may be inherited, it may be from infectious process like rheumatic fever, or it may be some other infections which can cause this stenosis. It is possible. Some viral infections claim to be do that like this, and degenerative processes, and that is called sclerosis. These are they are the main causes of the aortic stenosis. Remember that above the valve you see the sinus of Valsalva. Sinus of Valsalva. Here, the sinus of Valsalva are two. One on the right anterior, and the second one is the left anterior, which are giving the branches of the coronary. That is, the left coronary artery arising from the left sinus of Valsalva, and the right coronary artery arising from the right aortic sinus or sinus of Valsalva. It fills in the diastolic phase, not in the systolic phase. The flap on the aperture, it closes in the systole because high pressure in the aorta will definitely it will burst the coronary circulation within the systole. So the diastole will fulfill the requirements of the heart. Diastole, in diastole, the heart acquired its circulation, not in the systolic phase, but in the diastole. So normal diameter is, it is about 2 centimeter to 2.5 centimeter square. With mild stenosis is 1.5, it's moderate 1 to 1.4, and severe is less than 1.1 square meter, square centimeter. So 1.5 is okay, fine. Very patient may become, you can say, almost asymptomatic. While moderate and severe form of aortic stenosis will cause the definite clinical picture. So here you see there, an aortic stenosis occurs. What happened here after the systole, the pressure, the end systolic pressure or end systolic volume will become increased because of the aperture is small. So ejection fraction or stroke volume cannot be fulfilled properly. So there will be the left ventricular pressure over. Secondly, the pressure is there or end systolic volume is more, then it affects on this valve also, that is mitral valve. And it pushes the mitral valve up. The pressure mounts in the left atrium. Again, the cycle repeats with the pulmonary veins. Pulmonary venous hypertension occurs. Reflect on the right side as the secondary pulmonary hypertension. Reflects on the pulmonary trunk, and this pressure also leads to the insufficiency of the pulmonary valve and increases the volume overload there in the right ventricle, pressure also is increased there, and then it transmits in the same fashion in the tricuspid valve, and insufficiency of the tricuspid occurs. So this is the cycle is the same. The cycle starts here in the case of the aortic valve disease, and the cycle starts from the mitral area, and the same process, all the cycle, all the symptomatology depends upon this. That is the pressure overload. You can see because of the high pressure, you can see the pressure because of the high pressure. The heart should hypertrophy. It should be hypertrophy. Should compensate it. The clinical finding is try it always. That is shortness of the breath, angina, anginal pain, and syncopic attacks. DAS, DAS. Characteristic symptomatology occurring in these patients. Because the less blood goes in the heart, will be a mismatch between the supply and demand. Hypertrophy ventricle needs more supply. So there will be angina. Dyspnea occurs because of the pulmonary hypertension. Syncope occurs because there is the poor stroke volume. It's not sufficient to distribute enough blood into the brain. So transcerebral saturation will not fulfilled by this stroke volume. And that was syncope occurs in these patients. One of the main cause in the old age of syncope may be aortic stenosis oblique sclerosis. Pulse in this condition is because it has to push. This is anprotic limb, this is diprotic limb. You see here, in the normal pulse here, there is a plateau, the pit here, down there and down there. Anacrotic, diacrotic notch, diacrotic face. Here you see the ascending limb is more prolonged. Delays. This is called the pulsus parvus et tardus. Slow rising pulse. Slow rising pulse. Carotid pulse or radial pulse, both. In physical examination, again I will say do the same thing. Always remember. Inspection, because of the hypertrophy of the heart, left ventricle, there may be a bulge there on the left side. But there are no visible pulsations. No. On palpation, the apex beat may be displaced because of the hypertrophy more than 7.5 centimeters. If it is associated with the mitral regurgitation, then definitely it will push the left ventricle to more than 8 centimeters from the mediastinal line. And because of this high pressure, this apex beat is mostly heaving in type. The fingers go up and down, and there will be possibility of a thrill may be present because of the diastolic tree at the aortic area, while thrill because of the secondary mitral regurgitation. Systolic thrill may be present in the mitral area, and because of the functional TR, tricuspid regurgitation, and because of the functional pulmonary regurgitation, there may be thrill in these situations. So pansystolic or rather systolic thrill will be present, can be present at the apex and at the tricuspid area, and a diastolic thrill may be present at the aortic area as well as in the pulmonary area. It's possible. There will be heaving of the right ventricle because heart is failing now. The high pressure transmitted to the right ventricle. On auscultation, lot of findings may be present in all areas of the heart. First of all, starting from the aortic area, there will be a diastolic murmur in this condition. It may be short diastolic, it may be more prolonged diastolic murmur in the aortic area. This is on the left side. You enhance this murmur by saying the patient that he has to take full inspiration, then expire, and then bend down anteriorly. But this murmur can be easily appreciated and can be graded accordingly. Diastolic murmur, grade 1 or 2 or 3 or 4, because it is associated with a thrill, then it may be more than 2. It may radiate to the suprasternal notch. It may. Actually, the findings, I'm sorry about it, I was mixing with the aortic regurgitation, with aortic stenosis. There will be a systolic crescendo, decrescendo type of a murmur in this condition. If you say the patient, this murmur will be increased on expiration while it is decreased on the inspiration, systolic murmur. And I have actually mixed with the aortic regurgitation. That's why I said the diastolic murmur, the systolic murmur. It may be a short systolic murmur or it may be prolonged murmur. Crescendo, and it is moving up and then down. On it may radiate to the suprasternal notch or cover in carotids. While in cases of the aortic sclerosis, usually these murmurs are more appreciated in the right parasternal border upper part, and they do not radiate in most of the cases. And there will be, because of the heart is failing, S3 may be present. Because of the hypertrophy, there will be S4 you can hear, and there will be paradoxical S2, means that P2 comes first and S2 comes then later on. This is called paradoxical S2 because second component of S2 means A2 P2. Now here P2 and S2, B2 A2, P2 A2 now. Content of the pulmonary valve becomes more dominant. Laboratory findings are the same one. I said that it is just radiology, which I have not discussed. I will discuss later on. Electrocardiography, what we say is that most of the cases, the left ventricle hypertrophy, echocardiography confirm your findings. You go for the stress testing with angina or for compromisation of the coronary vasculature is concerned. Catheter-based studies can be done in the centers where the facilities are there to confirm that it is aortic stenosis. Remember, here I will say previously, there is a functional TR also, which is known as carvalosine. And there is a functional PR also, which is called as the gram steel murmur. And these murmurs are functional murmurs. In aortic stenosis here, heart size is not much problematic. Only thing they want to show here in this area that it may be possibly of calcification. Otherwise, this is ascending part of aorta. Aortic knuckle is not there, very clearly visible, is not clearly visible. It is the content of the pulmonary hypertension. There are changes in the lung fields also. I already said the hypertrophy. There will be left ventricular deviation, and there will be see the AVF, which should be down, and one is up. Calculate the axis minus 30, 100 or 110 is normal one. Here is more than minus 30, maybe minus 45 or minus 40. The second finding you will find here in these ECGs, maybe ischemic changes are seen, representing the angina. Third thing you will find here, the element of the hypertrophy. You will add S wave of V1 to the R wave of V5. It should be more than 35 millimeter. Only V6 is there, it is 26 millimeter more. These are the echo findings, thickening and more calcification and mobility reduced, left ventricular hypertrophy, etc. Doppler studies can be done. Definitely the pressure gradient here will be small, the blood pressure is, the pulse pressure will be narrow. Always remember, pulse pressure becomes narrow. You have to take the blood pressure in these patients. For example, it is 110 by 100, only 10 millimeter pulse pressure. On the opposite side, in the aortic valve regurgitation and insufficiency, the pulse pressure becomes white. That's why you say that this is dominant aortic stenosis or dominant aortic regurgitation or insufficiency. So these are the investigations and differential diagnosis because of the lot of murmurs are present here. Some murmurs are pansystolic murmur. We have to differentiate with the VSD then. Some murmurs are in the diastolic murmurs. We have to go for the differentiate it from the pulmonary primary pulmonary insufficiency, pulmonary regurgitation. While in case of the pulmonary stenosis, there is also systolic murmur. Systolic murmur here, systolic murmur here. Differentiate it because pulmonary side on the other side. This murmur will increase on the inspiration, not in the expiration. But this murmur of here, aortic stenosis, will increase in expiration, not in inspiration. All chest is full of murmurs. Most of them. It's a difficult one to differentiate which is the primary, which is the secondary, etc. A long discussion. I don't want to actually confuse the students and the postgraduates. I don't want to confuse them. Try to follow the basic principles of auscultation, timing, and other things, which I have already told. Management, medical management is the same. Go for the congestive cardiac failure therapy, and you manage the case as I previously said, general measures, specific measures, symptomatic measures, preventive measures, and we go for surgical measures, dietary measures. The, all columns should be fulfilled, whether applicable or not. If not applicable, say not applicable. For example, in general measures, you restrict the activity because patient is in failure. And a specific therapy, as a pharmacological is concerned, you have to give the therapy for the failure. Those agents which are reducing the preload should be given. Those agents should be given which decrease the demand of oxygen on the heart. And those agents should be given to reduce the afterload. Remember, the blood pressure should not drop. So captopril will drop blood pressure markedly, while Rosata in a 12.5, 6.5 will not reduce the blood pressure markedly. Just remember that the blood pressure should not drop. Otherwise, in the diastole, let's say there actually the pulse pressure is very, very low. The patient can go into the acute coronary syndrome. With septic treatment, other than that, symptomatically, you treat the patient on the basis of the symptoms. Pain in chest, referred pain, etc. You give analgesics, etc. If the oxygen is dropped, you give oxygen. And then we go for the preventive measures. We go for the secondary prevention. In this patient, we give the acetylsalicylic acid or clopidogrel. We give all these patients to HMG co-reductase inhibitors in a very low dose. These are the preventive measures you can do. The third preventive measure is very important. That is, if the other valves are normal, you have to give the injection Panadol LA, that is benzodiazepine penicillin, 1.2 million per month for whole life. Because other valves will be involved in the future. The surgical measures is that valve replacement. If young patients, do with the mechanical valves. In the old age patients, or patient pregnant, or patient is reluctant, or patient has got comorbids, etc., then biosynthetic, or what is known as the valves, they are membranous valves. The biosynthetic valves should be used. Bioprocessing, that is called. These valves are replaced by mechanical or bioprosthetic valves or tissue valves. The third procedure is called Ross procedure. Ross procedure is this: the pulmonary valve, which is healthy one, it will be transplanted to the aortic valve in the place of aortic valve, and you replace mechanical valve in the pulmonary area. And the patient should place on the warfarin sodium, and INR control should be 3.5. These are very important practical findings. These are the surgical measures. And then about the dietary measures, low sodium and fluid should be restricted to 1.5 ml or less than that. It should drink in a sips, because to reduce the load on the left ventricle. The local measures here can be done by placing the nitroglycerin patch, for example, will helpful. Patch of nitroglycerin. It is a coronary vasodilator. In this fashion, I will fill this. What general measures, specific measures, symptomatic measures, then go for the preventive measures, surgical measures if applicable, and then go for the dietary measures and local measures. Now, these are the adverse percutaneous valve can be inserted now. Endovascular insertion is possible. They are doing in Aga Khan as well as NICVT is a costly procedure. Adverse star adverse valve, this is called the tibial adverse percutaneous valve. It is a simple valve, although it is a mechanical valve. You see the outlines there made of specific alloy. It is placed by removal. First we remove aortic valve and then place it, this valve. Otherwise, the tissue valve will be used, bioprosthetic valves. Now, this is the end of the aortic stenosis is concerned as undergraduates and as postgraduate levels. This is a summarization of the aortic stenosis. You can see. Remember, the aortic stenosis is a degenerative process. After the age of 75, they say that incidence was recorded after the age of 75 to 80 years. It is more than 80% people are involved as a degenerative process. Some are asymptomatic and some are symptomatic accordingly. Uh, for example, angina in these patients are common. Breathlessness is common. Syncope is common at this age group. There are other causes of syncope in the old age as well, although aortic sclerosis can cause, severe aortic sclerosis can cause. Remember, there is also the congenital heart disease related with aortic valve called supravalvular stenosis. It is inherited, congenital. Bicuspid valve is another anomaly, and subaortic sclerosis is another congenital abnormality. I hope that any question arises from this session can be answered on the WhatsApp group. I hope that you have enjoyed this presentation well.